Paris called itself healed. By the time cafes spilled light onto the boulevards and orchestras played behind velvet curtains, France believed leprosy belonged to the Middle Ages, buried with monks, bells, and medieval fear. The Belle Époque wore confidence like perfume. Science had answers. Progress had arrived. The disease, they insisted, was gone. But leprosy did not disappear. It retreated. It slipped out of sight, into hospital wings with no windows, into distant asylums, into colonial territories where suffering did not interrupt Parisian evenings. It lingered in bodies that were no longer allowed to be seen, touched, or spoken of openly. Not because the illness was uncontrollable, but because it was inconvenient. It did not threaten society quickly enough to matter. It simply endured. This was a disease too slow for headlines and too unsettling for conversation. It disfigured without drama, isolated without urgency, and survived quietly beneath the polished surface of modern France, while society congratulated itself on moving forward. Before we go further, take a moment to settle in. If these hidden histories matter to you, if you're listening late at night or early before the city wakes, consider subscribing and let me know in the comments where you're listening from. There are many forgotten rooms still waiting to be opened. Tonight, we step into one of them, into the institutions no one visited, into the patients history learned to avert its eyes from. This is Leprosy in Belle Époque France. The Disease Society tried very hard to forget. By the final decades of the 19th century, France spoke of leprosy in the past tense. Medical journals referenced it as a historical curiosity, a remnant of crusades and cloisters, of bells rung in warning and figures wrapped in rags at the edges of medieval towns. In lecture halls and hospital corridors, it was listed alongside illnesses that civilization had outgrown, defeated not by miracle, but by order, hygiene, and enlightened administration. To name leprosy in modern France was to reveal oneself as outdated, indulgent in superstition, or quietly provincial. The Belle Époque thrived on declarations of closure. Old fears were dismissed. Old suffering was reclassified. Disease itself was meant to behave according to progress, appearing dramatically, provoking response, and vanishing under rational control. Leprosy did none of this. It refused to hurry. It refused to disappear cleanly. And so it was declared finished. This declaration was not made by law, nor by ceremony, but through omission. Public health bulletins stopped tracking it. Newspapers ceased reporting it. Hospitals no longer advertised wards devoted to it. The absence of conversation became proof of eradication. If no one spoke of leprosy, then leprosy must no longer exist. Yet medicine did not uncover truth through silence. It buried it. Physicians in Paris and Marseille still encountered patients whose symptoms followed an unmistakable pattern. Numbness that crept along the extremities, lesions that resisted explanation, faces that slowly lost expression. These cases were recorded cautiously, often under alternative diagnoses: peripheral neuropathy, chronic skin disorder, tropical ailment, anything but the word that no longer belonged. To label a patient as a leper was to invite administrative inconvenience. It raised questions no one wished to answer. Where would such a patient be sent? Who would pay for their isolation? How would the presence of such a disease reflect upon a nation convinced of its medical superiority? The answer, more often than not, was to rename rather than confront. France's confidence rested heavily on visible order. the rebuilt boulevards of Paris, the cleanliness campaigns, the regulation of housing and water, all were symbols of mastery over the physical world. Disease was permitted only when it arrived with force and demanded attention. Slow decay had no place in this narrative. Leprosy challenged not only the body, but the philosophy of the age. It suggested that modernity could coexist with ancient affliction, that progress might be layered rather than linear, that some conditions endured precisely because they were easy to overlook. The official stance became one of quiet dismissal. Leprosy, authorities claimed, survived only in distant lands, colonial territories with climates deemed incompatible with European health. Its presence within metropolitan France was described as anecdotal, isolated, unworthy of structured response, a statistical anomaly rather than a human reality. This belief hardened into doctrine. Medical textbooks reduced leprosy to a paragraph. Training hospitals offered no instruction in its management. Younger physicians completed their education without ever seeing a diagnosed case, because cases were no longer called what they were. And so, the disease entered a peculiar second life. Not feared, not confronted, but politely ignored. The declaration of leprosy's death was, in truth, an act of social convenience. It allowed France to maintain its self-image as a nation cleansed of medieval stain, a society advancing confidently toward the 20th century. It preserved the illusion that suffering could be solved simply by refusing to name it. But diseases do not obey reputations. They persist where they are allowed to persist. And leprosy, denied recognition and stripped of urgency, continued its work quietly, within bodies that were still very much alive, in a country that insisted it was cured. Progress in Belle Époque France was not merely a condition, it was a posture. It appeared in the straightened backs of new boulevards, in the measured efficiency of timetables, in the language of medicine that spoke confidently of causes, cures, and classifications. To be modern was to believe that uncertainty had been tamed. The 19th century had ended with the conviction that the body, like the city, could be mapped, regulated, and improved upon indefinitely. This confidence was not born of cruelty, but of success. Cholera had been studied, tracked, and, at least partially, contained. Tuberculosis was no longer mysterious, even if it remained deadly. Vaccination campaigns offered visible triumphs. Sanitation reshaped mortality itself. Each victory reinforced the belief that illness belonged to the realm of solvable problems, provided it announced itself loudly enough. Leprosy did not. It offered no sudden outbreak, no dramatic collapse, no moment that demanded urgent mobilization. Its pace was glacial, its symptoms ambiguous at first, its progression irregular. It did not fit the modern medical appetite for clarity, and so it was quietly excluded from the catalogue of diseases that mattered. The medical establishment of the era prized decisiveness. Diagnosis was expected to lead swiftly to intervention, intervention to improvement. Conditions that resisted this chain were uncomfortable. Leprosy lingered in uncertainty, months, sometimes years, before its nature could be unmistakably identified. By then, the patient had often already vanished from ordinary social life, withdrawn by circumstance rather than instruction. Progress, as it was understood, required visible outcomes. Hospitals were increasingly evaluated by efficiency, by recovery rates, by the speed with which patients moved through their wards and back into society. Leprosy offered no such reassurance. There was no cure to display, no triumphant discharge to record. It threatened to become a permanent resident in institutions designed for movement. Rather than revise their understanding of progress, physicians revised their definitions. Medical literature of the period reveals a subtle shift in tone. Leprosy was discussed less as a domestic concern and more as a theoretical condition, interesting in origin, educational in history, but irrelevant to the present. When cases appeared within France, they were framed as exceptions, curiosities, or imported remnants. The disease itself was repositioned as an artifact rather than an active threat. This intellectual distancing served a broader cultural purpose. The Belle Époque was invested in optimism. Its exhibitions celebrated machinery, speed, electricity, and light. To acknowledge the persistence of a disease so deeply associated with medieval exclusion was to fracture the narrative of uninterrupted advancement. It suggested that modern life had limits, an implication few were willing to entertain. Confidence hardened into dismissal. Doctors reassured themselves that improved hygiene alone rendered leprosy obsolete. Administrators accepted that belief without demanding evidence. The absence of outbreaks was mistaken for absence of cases. And because the disease rarely killed quickly, it escaped the metrics by which public health urgency was measured. Yet beneath this confidence lay an unspoken anxiety. Leprosy undermined the idea that visibility equaled control. It asked unsettling questions. What if not all diseases could be hurried? What if some forms of suffering persisted precisely because they did not disrupt society loudly enough to demand response? Rather than confront these questions, progress looked away. The faith in advancement did not eradicate leprosy. It rendered it inconvenient. And inconvenience, in an age devoted to momentum, was enough to justify neglect. The disease remained present, but stripped of legitimacy, drifting between diagnoses and institutions, while modern France assured itself that it had moved on. In believing so completely in progress, society failed to notice what it left behind. For centuries, leprosy had announced itself. It arrived with ritual, with sound, with unmistakable warning. Bells were rung not to summon aid, but to enforce distance. The afflicted were made audible before they were made invisible, identified in advance so the healthy could step aside. Fear was public, regulated, and loud. The disease was acknowledged precisely because it demanded response. By the Belle Époque, that noise had vanished. No bells rang in modern France for leprosy. No proclamations were issued. No public warnings marked its presence. The disappearance of sound was interpreted as proof of absence, as though silence itself were evidence of cure. In truth, silence was simply more convenient. Modern society prided itself on refinement. The crude gestures of earlier centuries, forced segregation, public shaming, ritualized exclusion, were now regarded as barbaric. France congratulated itself on having replaced superstition with science, cruelty with compassion, and yet, in discarding the bell, it discarded acknowledgement as well. Leprosy did not require noise to persist. It adapted easily to quiet. Without bells, there was no moment of recognition, no threshold where society paused and named the danger. Instead, cases dissolved into private spaces, homes, back wards, peripheral institutions, where they could be managed without spectacle. The disease lost its public identity and became a matter of administrative discretion. This transition from announcement to omission marked a profound shift in responsibility. In earlier eras, the community had been forced to confront the presence of the afflicted, however brutally. In modern France, the burden was transferred to the individual. Illness became something to manage discreetly, to conceal, to endure without disturbing others. Silence carried moral weight. To speak of leprosy was to risk social discomfort. It suggested contagion where society wished to see cleanliness, decay where it preferred progress. Physicians learned quickly which words unsettled donors, administrators, and colleagues. Better to describe symptoms without naming their cause. Better to record ambiguously. Better to keep the disease confined to charts rather than conversation. Hospitals reflected this change. Wards once dedicated openly to leprosy were absorbed into broader categories. Patients were placed among those with chronic conditions, neurological disorders, or obscure dermatological complaints. Their presence was diluted, their diagnosis softened. Without formal designation, there could be no public concern. Silence, however, did not eliminate fear. It refined it. Rather than communal alarm, there emerged private unease. Neighbors noticed gradual changes and chose not to inquire. Families observed symptoms and delayed consultation. Employers found reasons to dismiss without explanation. Fear no longer announced itself. It operated through avoidance. The absence of bells also meant the absence of memory. Without sound, there were no rituals to remind society of what persisted. Leprosy slipped out of collective awareness, surviving only in outdated texts and distant associations. It became something one assumed no longer existed, precisely because it was no longer named. This forgetting was not accidental. It was cultivated. Silence allowed modern France to maintain its sense of order. It prevented disruption. It preserved the image of a society moving forward without residue. The disease was not defeated. It was muted, carefully lowered until it no longer interfered with the rhythm of daily life. Yet silence is not the same as resolution. It merely changes who must listen. For those who lived with leprosy, the end of bells did not mean acceptance or relief. It meant isolation without recognition, suffering without language. A condition endured quietly, in rooms where no warning ever sounded, because society had decided it no longer wished to hear. Cleanliness became the visible proof of virtue. By the height of the Belle Époque, France measured its health not by the bodies within it, but by the surfaces it presented. Streets were scrubbed, facades restored, refuse regulated, water filtered and inspected. Public hygiene campaigns promised not merely comfort, but moral reassurance. A clean city, it was believed, could not harbour ancient disease. Paris gleamed accordingly. The widened boulevards swept away the cramped medieval quarters that had once been blamed for illness. Light and air were permitted to circulate freely. Sewer systems were praised as triumphs of engineering. The city itself appeared disinfected, reborn as a space where decay had no place to settle. Yet this obsession with visible cleanliness masked a more troubling reality. Hygiene had become performative. It addressed what could be seen, measured, and admired, while quietly neglecting what unfolded slowly and privately within the human body. Leprosy did not offend cleanliness in obvious ways. It did not spill into streets or taint water supplies. It did not announce itself through filth or stench. It emerged gradually, subtly, often in individuals who otherwise conformed perfectly to society's expectations of order. This made it incompatible with a public health philosophy built on spectacle. Clean streets encouraged a dangerous assumption that disease followed dirt. Medical authorities increasingly linked illness to environmental neglect. Poor sanitation became the favoured explanation for suffering. Where streets were clean, disease was presumed absent. Leprosy confounded this logic. It appeared in orderly homes, among disciplined populations, without violating any of the visible rules of hygiene. Rather than challenge their assumptions, officials reclassified the disease as external, foreign, imported, or residual. Its presence within France was reframed as anomaly rather than evidence. The illusion of cleanliness demanded that contradiction be removed. Public health measures reflected this bias. Resources flowed toward conditions that threatened public appearance: epidemics, overcrowding, visible decay. Slow illnesses received attention only insofar as they could be linked to sanitation campaigns. Leprosy, offering no such connection, was left without advocacy. The city's cleanliness thus became a shield, deflecting inquiry rather than inviting it. Hospitals too mirrored this priority. Institutions proudly displayed modern wards, sterile equipment, and regimented routines. Patients who fit the narrative of recoverable illness moved through these spaces efficiently. Those who did not, those whose conditions resisted cure or defied categorization, were quietly redirected elsewhere. Leprosy patients often disappeared into administrative margins. Their presence complicated the image hospitals wished to project. Chronic care did not photograph well. Prolonged decline disrupted the narrative of medical success. Cleanliness demanded turnover, and leprosy offered permanence. This fixation on surface purity extended beyond infrastructure. Bodies themselves were evaluated according to visible compliance. A person who appeared clean, well-dressed, and composed was assumed healthy. Symptoms that developed slowly were dismissed until they became undeniable, and by then the patient had often already been isolated socially. Cleanliness became a language of denial. It allowed society to believe that disease could be washed away, swept aside, rendered irrelevant by sufficient effort. It transformed health into an aesthetic achievement rather than a complex reality. And in doing so, it left those whose suffering did not align with appearance without protection or acknowledgement. The truth remained, unclean and inconvenient, that disease does not always respect order, and that cleanliness, however admirable, is not cure. But the Belle Époque preferred its streets immaculate, and its truths carefully obscured. Optimism in the Belle Époque was considered a professional virtue. Physicians were expected to believe, not merely in their skill, but in the inevitable forward motion of medicine itself. Doubt belonged to earlier centuries. Hesitation suggested incompetence. The modern doctor spoke with confidence, diagnosed decisively, and trusted that science, if not today, then soon, would resolve what remained unclear. This confidence shaped what medicine chose to see. The late 19th century was an era of discovery. Bacteria identified, transmission theories refined, laboratories elevated to near sacred status. Disease was no longer mysterious. It was observable, measurable, conquerable, or so it seemed. The profession's gaze sharpened toward illnesses that rewarded investigation quickly and dramatically. Leprosy did not. Its progression was slow, its manifestations inconsistent, its causes frustratingly resistant to tidy explanation. Even as the bacterium responsible was identified, This knowledge offered little practical triumph. There was no swift cure to follow discovery, no immediate reversal of symptoms. For a medical culture increasingly addicted to results, leprosy offered only endurance. And endurance did not inspire optimism. Rather than accept this limitation, medicine adjusted its focus. Diseases that responded well to intervention dominated research, teaching, and funding. Those that lingered awkwardly, defying improvement, were quietly sidelined. Leprosy fell into this category, not because it was rare, but because it was unrewarding. Medical optimism created blind spots, not through ignorance, but through selection. Young physicians were trained on cases that illustrated progress, recoveries, improvements, measurable success. Chronic decline had little pedagogical value. Leprosy patients, whose conditions changed slowly and unpredictably, offered no clear lessons within the new scientific framework. They became marginal figures in teaching hospitals, present but peripheral. This marginalization influenced diagnosis itself. Doctors, conditioned to expect certain patterns, often overlooked early signs. Numbness, minor lesions, fatigue, these were attributed to more fashionable conditions or dismissed as trivial. To consider leprosy required abandoning optimism, and few were inclined to do so. Even when suspicion arose, confirmation was approached cautiously. A leprosy diagnosis carried weight beyond medicine. It implicated institutions, provoked administrative complications, and threatened reputations. Hospitals that prided themselves on modern efficiency were reluctant to admit conditions that suggested lingering failure. Thus, uncertainty was prolonged. Symptoms were monitored rather than named. Patients were observed rather than informed. Medical optimism meant to heal, instead delayed recognition. Blind spots widened as responsibility diffused. Each physician assumed rarity, exception, coincidence. Without centralized attention, patterns went unrecognized. The disease remained scattered across records, never accumulating sufficient visibility to demand response. Scientific journals mirrored this neglect. Articles on leprosy became increasingly theoretical, focusing on distant populations or historical contexts. Domestic cases were underreported, framed as anomalies rather than evidence. The disease was discussed safely at arm's length. Optimism also influenced treatment philosophy. Without a cure, care became minimal, focused on containment rather than comfort. Patients were monitored, not engaged. Their condition was documented, but rarely challenged. Medicine observed, but did not intervene meaningfully. This was not cruelty, but confidence misplaced. By believing too firmly in progress, medicine overlooked what progress had not yet solved. Leprosy occupied that uncomfortable space, known, named, yet unresolved. And in an age that equated knowledge with victory, unresolved conditions were quietly pushed aside. The blind spot was complete. A disease acknowledged in theory, ignored in practice, surviving precisely because no one believed it still mattered. Belief, once established, demanded maintenance. By the close of the 19th century, France had invested too much in the idea of its own medical triumph to permit contradiction. Leprosy's disappearance was not merely assumed, it was required. The belief had hardened into an expectation, and expectations, once shared, became policies without ever being written. The cost of this belief was not immediately visible. It did not announce itself through crisis or collapse. Instead, it accumulated quietly, in delayed diagnoses, in administrative evasions, in patients who passed through institutions without ever being properly named. To believe that leprosy no longer existed was to shape every subsequent decision around that assumption. Budgets reflected it. Training reflected it. Infrastructure reflected it. There were no dedicated programs, no modernized facilities, no centralized oversight. The disease, officially obsolete, was granted no space in the present. Doctors who encountered suspected cases were left without guidance. There were no clear pathways for referral, no standardized protocols for isolation or long-term care. Each case became an individual burden, managed discreetly and inconsistently. Responsibility dissolved into improvisation. Belief also shaped language. Medical reports softened terminology. Administrators avoided explicit classifications. The word itself, leprosy, appeared less frequently, replaced by clinical euphemisms that obscured meaning while preserving order. The disease became linguistically diluted, its reality softened by phrasing that reassured rather than alarmed. This linguistic restraint was not neutral. It altered outcomes. Without clear diagnosis, patients were denied access to whatever limited resources might have existed. Without acknowledgement, there could be no advocacy. Without naming the disease, society absolved itself of obligation. The burden shifted decisively onto the afflicted. Patients bore not only the physical consequences of leprosy, but the administrative consequences of disbelief. They were shuffled between wards, reassigned diagnoses, transferred quietly to peripheral institutions. Each movement reduced visibility, reduced continuity of care, reduced the likelihood that anyone would take responsibility for the whole of their condition. Families absorbed the cost as well. Without official recognition, there were no formal protections, no clear instructions, no public acknowledgement of risk or need. Relatives navigated fear privately, uncertain how to act, reluctant to speak. Isolation occurred not through law, but through hesitation. Belief also shielded institutions from scrutiny. Hospitals could claim modernity while housing unaddressed suffering. Public health authorities could celebrate sanitation victories without confronting conditions that resisted environmental solutions. The absence of leprosy from reports became evidence of success, even as cases quietly persisted. In this way, belief became self-reinforcing. Each year, without acknowledgement, confirmed the assumption of eradication. Each unreported case strengthened the illusion. The system learned to interpret its own silence as validation. But belief exacts a price when it replaces observation. Leprosy, deprived of attention, did not disappear. It endured under poorer conditions. Without research focus, treatments stagnated. Without institutional priority, care remained minimal. The disease's slow progression meant its consequences unfolded over decades, not months, allowing neglect to masquerade as normalcy. The true cost of belief was measured not in statistics, but in lives lived without recognition, in patients who were never fully diagnosed, in suffering that was managed but never addressed, in a society that congratulated itself on progress while quietly abandoning those who complicated its narrative. Belief had simplified reality, and in doing so, it had chosen convenience over truth. The first sign was almost always small enough to ignore: a patch of skin that no longer responded to touch, a finger that burned without cause, then felt nothing at all, fatigue that lingered after rest, weakness that refused explanation. In a medical age trained to look for urgency, these symptoms were too modest to command attention. They did not alarm. they inconvenienced. Leprosy entered the body quietly. It did not announce itself with fever or collapse. It settled instead into nerves and skin, advancing slowly, almost politely, as though aware that haste would invite discovery. Weeks passed, months, sometimes years. By the time the illness could no longer be denied, the body had already been altered in ways medicine could not easily reverse. Physicians were trained to expect improvement. When treatment failed to produce results, the assumption was not persistence, but misclassification. The body, after all, was expected to respond. When it did not, the fault was presumed to lie in diagnosis rather than reality. Thus, these bodies were reinterpreted repeatedly. Numbness was attributed to exhaustion. Lesions were treated as chronic irritation. Muscle weakness was blamed on labor, age, or nerves. Each explanation deferred confrontation. Each adjustment delayed recognition. The body, meanwhile, continued its slow deterioration. Leprosy resisted the language of recovery. Wounds healed imperfectly. Sensation returned only partially, if at all. Infections followed unnoticed injuries. Limbs weakened not dramatically, but persistently. The body did not collapse. It endured, and endurance was easily mistaken for stability. This endurance became its own form of invisibility. Patients often continued their routines long after illness had taken hold. They worked. They walked the same streets. They appeared, at first glance, intact. Only gradually did signs accumulate. Subtle asymmetries, stiffness, a hand that no longer closed properly. These changes were easy to dismiss, especially in a society accustomed to hiding discomfort. Medical optimism interpreted resilience as reassurance. If the patient could still function, then the condition could not be serious. If the disease were truly dangerous, surely it would behave accordingly. Leprosy violated this expectation. It did not incapacitate quickly. It lingered, undermining the body without forcing intervention. As symptoms progressed, patients often found themselves cycling through consultations. Each visit yielded adjustments, but no clarity. Treatments were attempted, abandoned, replaced. The body became a site of experiment rather than understanding. No single physician claimed ownership of the case. Responsibility dispersed, and so the body remained untreated in the ways that mattered most. By the time deformities emerged, the disease had already secured its position. Fingers stiffened, facial muscles weakened, vision blurred. These changes, once visible, provoked discomfort, not urgency. The patient was no longer simply ill, but unsettling. Medicine, confronted with a body it could not restore, retreated emotionally, if not physically. Such patients were described as difficult, chronic, or unfortunate. Their presence disrupted routines designed around cure. They required long-term attention without offering resolution. In institutions focused on efficiency, this made them unwelcome. The body that would not heal became an administrative problem. Transfers followed. Patients were moved to less prominent wards, then to peripheral institutions. Each relocation reduced continuity of care. Records followed imperfectly. Knowledge fractured. The body remained, but understanding did not. What made leprosy particularly cruel was not only its physical effects, but its refusal to grant permission for alarm. It did not demand action. It invited neglect. And in an age that equated danger with immediacy, this quiet persistence proved devastating. These bodies bore the cost of disbelief long before society acknowledged it. They carried within them a disease declared obsolete, progressing steadily beneath the assumptions of a modern age that had decided such suffering no longer belonged. Diagnosis, once a declaration, had become a negotiation. In earlier centuries, to name leprosy was to alter a life irrevocably. It triggered ritual, removal, and unmistakable separation. By the Belle Époque, such declarations were considered unthinkable, too crude, too medieval, too disruptive for a society that prized discretion. And so, diagnosis did not disappear. It learned to whisper. Physicians still recognized the signs. They had to. The progression was familiar, even if it was no longer discussed openly. Loss of sensation followed predictable paths. Lesions appeared where nerves weakened. Muscles failed not randomly, but according to patterns long documented. The knowledge had not vanished. Only the willingness to speak it aloud had. To diagnose leprosy openly was to invite consequence. Hospitals would be forced to act. Administrators would be alerted. Questions would be asked about containment, responsibility, and reputation. A single confirmed case threatened to puncture the illusion that modern France had left such diseases behind. And so, certainty was postponed, diluted, or buried beneath technical ambiguity. Doctors learned to communicate diagnosis indirectly. Patients were told they had a chronic condition, a nerve disorder, a skin disease that required monitoring. Language softened edges. It offered reassurance while withholding truth. This was not done purely out of cruelty, but out of habit, an inherited caution shaped by institutional pressure. Medical notes told a different story. Charts recorded observations carefully, often hinting at the true nature of the illness without naming it outright. Question marks appeared beside terms. Diagnoses were written in pencil rather than ink. Words were chosen to preserve flexibility. This allowed physicians to acknowledge reality privately while avoiding official recognition. The result was a diagnosis that existed without consequence. Patients sensed this hesitation. They were examined repeatedly, referred quietly, told to return again and again. They understood that something was wrong, but were never given the language to articulate it. Uncertainty became their condition as much as the disease itself. This ambiguity served the system well. Without formal diagnosis, there could be no legal requirement for isolation, no demand for specialized care, no public acknowledgement. Patients could be managed quietly, shifted between services, absorbed into institutions not designed for their needs. Each step reduced visibility. For the afflicted, diagnosis without announcement was a peculiar limbo. They were neither fully ill nor officially healthy. They were not declared dangerous, yet found themselves avoided. Employers noticed changes and quietly dismissed them. Families sensed something unspeakable and adjusted behavior accordingly. The patient existed in a state of partial recognition, suspected but never confirmed. This half-knowledge was isolating. Without a name, suffering could not be shared. Without acknowledgement, there could be no advocacy. Patients learned to describe their condition vaguely, mirroring the language used by physicians. They internalized the silence imposed upon them. Even within medicine, this quiet diagnosis fractured responsibility. No single doctor owned the truth. Each passed the patient along, reassured by the absence of formal declaration. The disease persisted across appointments, institutions, and years, never accumulating enough certainty in one place to demand action. Diagnosis had become a means of containment, not of disease, but of discomfort. By avoiding announcement, society avoided reckoning. The illness remained manageable precisely because it remained unnamed. It did not provoke panic, but neither did it provoke care. Leprosy survived not because it was misunderstood, but because it was understood too well, and deliberately kept quiet. Leprosy did not take, it stayed. Its cruelty lay not in sudden loss, but in duration. Where other illnesses advanced swiftly toward resolution, either recovery or death, leprosy unfolded over years, sometimes decades. It allowed life to continue just long enough to make decline feel ordinary. This was not an illness that interrupted existence. It accompanied it. The long decline began subtly, almost deceptively. Sensation dulled first. Touch lost its precision. Heat and cold became unreliable guides. Small injuries went unnoticed, then untreated. A burn blistered without pain. A cut deepened without alarm. The body ceased to warn its owner, and in doing so began to betray them. Muscle weakness followed, but unevenly. One hand faltered while the other remained strong. A foot dragged slightly, then compensated. These asymmetries were easily explained away. Fatigue, age, strain. The decline never arrived all at once. It came in increments small enough to accept. Acceptance became habit. Patients adapted constantly. They learned to adjust movements, conceal changes, modify routines. Buttons were replaced with hooks. Shoes were altered. Mirrors were avoided. The body changed, but quietly enough that it could still be presented to the world with effort. This endurance was mistaken for resilience. Medical observers noted progression, but rarely intervened decisively. Without acute crisis, there was no urgency. Treatment focused on managing complications, rather than addressing cause. Infections were cleaned, wounds were dressed. Pain, when it arrived, was dulled. The disease itself remained untouched. Time became the primary agent. Months passed into years. Each year brought new limitations. Loss of grip, altered gait, blurred vision. Facial muscles weakened subtly, expression stiffening until emotion appeared muted or distorted. The patient learned to speak less, smile less, engage less, not because of despair, but because the body no longer cooperated. Social withdrawal often preceded physical collapse. Friends noticed changes and adjusted their distance. Conversations shortened. Invitations ceased. There was no formal exclusion, no explicit rejection. The decline itself created separation. The patient faded from view gradually enough that no one felt responsible for the disappearance. The long decline also eroded hope. Without clear diagnosis or prognosis, patients lived in uncertainty. They were told to wait, to observe, to manage symptoms. Improvement was always implied, rarely delivered. Each visit promised monitoring, not resolution. The future remained deliberately vague. Institutions, too, relied on time. Long-term patients were absorbed into systems designed for permanence rather than care. Sanatoria, chronic wards, peripheral hospitals, places where nothing urgent was expected to happen. Here, decline was normalized. It blended into routine. Records reflected this resignation. Notes grew shorter. Observations became repetitive. The disease was no longer actively studied. It was endured alongside the patient. Progression was acknowledged, but not challenged. Leprosy's power lay in this patience. It outlasted attention. It wore down concern. It transformed suffering into background noise. By the time consequences became undeniable, they were no longer shocking, only expected. The long decline did not provoke outrage or reform. It provoked silence. And in that silence, bodies changed slowly, lives narrowed quietly, and a disease officially forgotten continued its work without interruption. There came a moment when concealment failed. Leprosy spared no particular region of the body, but its most devastating work was often reserved for the face, the one part of the self society insisted upon reading constantly. Long before speech, posture, or gesture, the face was how a person was judged. It carried trust, familiarity, recognition. When leprosy reached it, the consequences extended far beyond the medical. The changes were gradual, almost courteous in their arrival. Muscles weakened unevenly. Eyelids failed to close completely. Brows lost their responsiveness. The mouth stiffened, corners refusing to lift as they once had. Expression did not vanish all at once. It thinned, dulled, became unreliable. Emotion was still felt, but no longer easily displayed. Observers misread this as indifference. Friends mistook stiffness for coldness. Strangers perceived withdrawal where none was intended. The face, no longer fluent in social language, betrayed its owner constantly. Each encounter became an effort to compensate for features that would not cooperate. As the disease progressed, physical alterations became harder to disguise. Swelling altered proportions. Lesions left marks that no powder could fully conceal. Facial hair was grown or shaved strategically. Hats were worn low. Veils appeared where they had never been worn before. The face was managed like a liability. Medical professionals responded with quiet discomfort. Doctors examined patients clinically, but avoided prolonged eye contact. Nurses learned efficiency over empathy. There was nothing to be done for appearance, and so it was treated as irrelevant, despite the fact that it shaped every aspect of the patient's remaining social life. The face became the boundary where discretion failed. Hands could be gloved, limps could be explained, fatigue could be hidden. But the face announced difference immediately. It disrupted the illusion of normalcy upon which modern society depended. And because leprosy had been declared obsolete, these faces became unsettling anomalies, evidence of something that should not exist. Society responded not with fear, but with avoidance. No bells were rung, no warnings issued. Instead, glances shortened. Conversations ended quickly. The patient learned to watch others recoil slightly, then recover, pretending nothing had happened. Politeness replaced honesty. Discomfort went unspoken. This silent rejection cut deeply. To be avoided without explanation was more isolating than formal exclusion. There was no rule to resist, no decree to challenge, only a steady retreat of human connection. The patient became hyper-aware of mirrors, reflections, shop windows. Each surface offered confirmation of what others saw. Families struggled as well. Loved ones insisted nothing had changed, yet their behavior betrayed caution. Touch softened, then diminished. Photographs were avoided. The face, once familiar, became something difficult to acknowledge without confronting reality. Institutions absorbed these patients readily, not out of compassion, but convenience. Within hospital walls, faces no longer needed to be explained. Everyone was altered in some way. Outside, difference demanded reaction, and so the face became the final reason for disappearance. Patients withdrew, not because they were ordered to, but because presence had become unbearable. Public life required a face that could be read correctly. Leprosy rendered that impossible. These were not faces of contagion, nor of moral failure. They were faces shaped by time, neglect, and a disease society insisted no longer existed. And because they could not be shown without unsettling the illusion of progress, they were slowly removed from view until the streets appeared clean once more. Illness rarely belonged to one body alone. When leprosy entered a household, it did so quietly, without announcement or instruction. There were no officials at the door, no formal guidance issued by authorities. Families were left to interpret what they saw, to negotiate fear and care without language or reassurance. And because the disease was no longer officially acknowledged, there was no sanctioned way to respond. At first, families adjusted gently. A chair was moved closer to the fire. Tasks were redistributed without explanation. Conversations skirted around symptoms. Loved ones insisted nothing was wrong, even as routines shifted. This early adaptation was framed as kindness, an attempt to preserve normalcy for as long as possible. But uncertainty breeds distance. Without clear diagnosis, fear had no boundaries. Family members did not know what precautions were necessary, or whether any were required at all. Touch became hesitant. Shared objects were cleaned more frequently. Bedrooms were rearranged. None of this was discussed openly. Silence was assumed to be protective. The absence of official acknowledgement forced families into private decision-making. There were no rules to follow, only instincts shaped by rumor and half-remembered histories. Medieval images lingered beneath modern confidence: bells, exile, contamination. Even when reason dismissed these fears, the body remembered them. Gradually, stepping back became habit. Meals were eaten separately under the guise of convenience. Physical affection diminished, replaced by verbal reassurance. The ill family member was included, but differently, present, yet subtly apart. This separation was rarely named. To name it would require admitting what no one wished to say. Children learned quickly. They observed adults' behavior and mirrored it. They asked fewer questions. They avoided contact without being told to do so. The disease was not explained, but it was understood, absorbed through gesture rather than instruction. Families often convinced themselves this distance was temporary. Once treatment worked, once strength returned, things would resume as before. This hope lingered even as years passed and decline continued. Belief in improvement replaced preparation for permanence. When symptoms worsened, families faced difficult choices without guidance. Should the patient be sent elsewhere for care? Would specialized institutions help or harm? Was it safer to keep them close, or kinder to remove them from daily strain? These decisions were made quietly, often framed as necessity rather than rejection. Sending a loved one away was rarely described as abandonment. It was justified as medical prudence, financial reality, or logistical necessity. Institutions offered relief, not just from care responsibilities, but from confronting the disease daily. Families told themselves this was best for everyone involved. And once separation occurred, return became unlikely. Visits grew infrequent. Distance, once established, proved easy to maintain. Letters replaced presence. Care became abstract. The patient's absence slowly redefined family life, until their place was remembered more than felt. This stepping back was not born of cruelty. It was shaped by uncertainty, fear, and a society that provided no framework for compassion. Families were left alone to manage an illness officially deemed irrelevant, yet personally devastating. In learning to step back, families preserved their own stability, but at the cost of intimacy. And so, leprosy fractured households quietly, not through force, but through the slow erosion of closeness under the weight of silence. To exist without acknowledgement is a peculiar form of exile. In the Belle Époque, patients with leprosy continued their lives under a dual reality, visible to themselves and to those around them, yet officially absent from the world. Society had decided, through omission and careful management, that leprosy no longer existed. The patient, however, remained, moving through spaces that insisted upon their normalcy while refusing to recognize the change occurring within the body. Daily life became a careful performance. Simple routines, meals, travel, errands required constant calculation. Every gesture, every expression had to be measured against the unspoken expectations of observers. Physical limitations imposed by the disease had to be concealed or explained as accident, fatigue, or habit. To falter, to reveal the truth of the illness, risked discomfort, avoidance, or even silent judgment. The world was unforgivingly observant. In cafes, colleagues noted hesitation in handshakes or subtle differences in posture. In homes, family members adjusted seating arrangements, softened touches, whispered explanations, or avoided contact altogether. A simple cough, a minor tremor, a delayed response, all were magnified in their significance. The patient became a silent anomaly, never named, yet always felt. Employment was a delicate negotiation. Those who could continue to work did so with difficulty. Their limitations were tolerated only as long as they remained discreet. Supervisors reframed inefficiency as distraction or fatigue. The invisible nature of the disease allowed for plausible deniability, yet constant vigilance was required to maintain it. Every interaction carried risk. A curious glance, an unguarded question, a whispered concern. Medical care offered only partial relief. Doctors recorded symptoms cautiously, offering treatment for individual complaints, rather than addressing the whole condition. Visits were sporadic, follow-ups perfunctory. Hospitals provided shelter and minimal observation, but did not admit to the existence of leprosy in any comprehensive sense. Knowledge of the disease persisted privately, documented in records carefully filed away, yet absent from the public consciousness. Isolation became habitual. Social gatherings were endured with restraint. Invitations declined or delayed. Relationships subtly adjusted. Children learned to mirror adult caution. Friends hesitated to touch or engage. Invisibility was imposed not through law, but through the subtle choreography of avoidance. Psychological burdens grew alongside physical ones. To live unacknowledged was to internalize society's denial. Patients were aware that their condition existed in tension with public belief. Anxiety, shame, and loneliness were constant companions. Yet these emotions had no social outlet, no acknowledgement from peers or institutions. Expression had to be moderated, or risk further alienation. Yet life persisted. Some patients found solace in routines and habits. Gardening, reading, writing, or solitary work provided structure and distraction. Moments of genuine connection, though fleeting, were treasured precisely because they defied the imposed silence. Adaptation became a skill honed over years, teaching resilience under conditions deliberately understated. To live while unacknowledged was not merely to survive the disease. It was to navigate a society that refused to name it, to negotiate presence in a space that officially claimed the patient's absence, and to endure the subtle, constant reminders that progress and cleanliness had become a veneer, one that required the suffering to remain hidden to preserve the illusion. And in this quiet endurance, life continued, measured in private victories, invisible losses, and the ceaseless maintenance of dignity in a world determined not to see. By the Belle Époque, geography had become an instrument of discretion. Leprosy, that lingering disease of slow decay, was no longer to be addressed in the bustling heart of Paris, nor in the elegant districts of Marseille. It was inconvenient for the city to acknowledge it, inconvenient for progress to recognize that medieval afflictions still persisted. And so, carefully, deliberately, the afflicted were relocated to the peripheries, hospitals at the edges of maps, wards placed where they might be seen as distant curiosities rather than present realities. These institutions bore the hallmarks of efficiency and order, but their purpose was as much symbolic as medical. Wards were clean, the corridors swept, the walls painted a pale neutrality, designed to reassure visiting inspectors and administrators. Yet beneath this facade lay a silent understanding. Those who entered were not meant to return to the world unchanged. They were to be managed quietly, observed without fanfare, and kept away from the public gaze that might force recognition of a truth society had chosen to ignore. The journey to such hospitals was itself a passage into a liminal existence. Patients travelled under supervision, guided along routes designed to minimize encounters. Local populations were advised of their presence only insofar as necessary for safety. The disease was acknowledged, but only in the abstract. Names were recorded, rooms assigned, but the lies within were treated as secondary, less immediate than the smooth operation of the institution itself. Once inside, the patient entered a world defined by routines and boundaries. Meals were delivered on schedules that measured efficiency rather than appetite. Treatments were administered according to protocol, not to individual need. Nurses moved swiftly through corridors, noting changes, adjusting dressings, recording symptoms, yet rarely offering comfort beyond what was necessary to maintain order. The body was catalogued, measured, and monitored. The person within it was expected to adapt. Isolation was omnipresent. Rooms were designed to reduce contact. Windows faced gardens or courtyards rather than streets. Conversation was limited. Visitors were discouraged. The hospital operated like a city unto itself, where time was measured in rounds, meals, and observations rather than social engagement. For many patients, this seclusion became a new normal, a space where the slow progression of the disease could unfold without disrupting the world outside. Yet distance did not erase fear. For those confined, every corridor echoed with the tension of invisibility. Staff moved with efficiency, but efficiency implied caution, and caution implied danger. Patients were aware that their presence had to be hidden, their symptoms muted. Each glance, each step, each cough was measured against the unspoken rules of propriety. To attract attention was to risk shame or dismissal. Administrators benefited from this spatial arrangement. By locating leprosy at the edges of maps, the disease could be recorded without disrupting narratives of public health and progress. Statistics could be managed, reports edited, and the illusion of eradication maintained, even as the illness continued its quiet work. And so, the edges of France became repositories for the overlooked, the persistent, and the inconvenient. Hospitals at the peripheries were not merely places of care. They were instruments of societal denial, carefully calibrated to allow the disease to exist without disturbing the self-image of a nation convinced it had long since conquered the past. Within those walls, leprosy endured. The city beyond might sparkle, the boulevards shine, and the cafes hum with optimism. But at the edges, lives were quietly consumed, managed and made invisible. And in that careful removal, society preserved its confidence, leaving the truth to unfold in silence. Sanatoria promised order and care, yet offered little hope of restoration. In the Belle Époque, these institutions were presented as triumphs of medical foresight. Buildings designed for light and air, corridors spacious enough to allow circulation, gardens where patients could walk in measured exercise. On paper, they were ideal. In practice, they were places where leprosy could persist undisturbed, observed but rarely reversed, acknowledged but never confronted fully. The architecture itself was instructive. High ceilings, large windows, and carefully arranged wards gave the impression of openness and transparency. Visitors, inspectors, and junior physicians were impressed by the cleanliness, the efficiency, the modernity. Yet the careful arrangement served another purpose. It kept the disease contained visually and socially. It separated the afflicted from the world that refused to see them without admitting failure. The sanatorium was a theatre of invisibility, where suffering was managed as a spectacle of control, rather than a human condition requiring intervention. Inside, life followed strict routines. Meals arrived at fixed hours, often prepared for hygiene rather than nourishment. Patients were encouraged to walk in measured increments, perform exercises designed more to demonstrate activity than to improve strength, and to participate in occupational tasks that disguised idleness. Days were divided by observation and record-keeping rather than therapy. Nurses and physicians moved briskly, attending to practical needs, noting changes in charts, and rarely pausing for extended interaction. The body was monitored. The person inhabiting it was quietly sidelined. The absence of recovery became normalized. Patients understood that the disease was not expected to reverse itself. Lesions would persist, deformities would slowly accrue, and sensation might never return. Yet the institution required compliance with routines that implied progress, as if the regularity of care could substitute for actual improvement. Patients were instructed to follow instructions, maintain posture, and adhere to regimen. Their obedience became a proxy for wellness, though their bodies told another story. Isolation, both physical and social, intensified the experience. Wards were arranged to minimize cross-contact, reducing the possibility that one patient's deterioration might alarm another or draw the attention of external visitors. Windows faced internal courtyards rather than streets. Meals were taken at staggered intervals. Conversation was limited. The silence of supervision mirrored the silence of society. The disease existed, but quietly, and the less it was acknowledged, the easier life seemed to be. Staff acted within constraints imposed by confidence in progress. Medical texts had little guidance for chronic cases resistant to intervention. Experimental treatments were applied selectively and inconsistently. Patients were observed, but active attempts at cure were rare. In this way, sanatoria became places of containment rather than restoration. Disease was managed, not eradicated. Even as time passed and bodies deteriorated, the institution maintained its image. Reports emphasized hygiene, adherence to routine, and low rates of apparent complication. They did not emphasize the slow accrual of disability, the persistence of infection, or the quiet despair of isolation. The sanatorium, like the city outside, was a statement. Here, society had control, progress reigned, and the medieval past had been vanquished. Yet, within these walls, leprosy continued its unhurried work. Patients endured decline, observed but not fully treated, their suffering regulated for the convenience of a society unwilling to name it. Sanatoria offered cleanliness and structure, but recovery remained elusive. And in that unspoken reality, the disease silently outlasted the optimism that believed it had disappeared. In Belle Époque France, even buildings spoke of restraint and discretion. Sanatoria and hospitals were no longer mere spaces of treatment. They were instruments of social and medical control, designed with purpose beyond hygiene or efficiency. Each corridor, each wall, each window was measured not only to facilitate care, but to manage perception, both of the patient and of society that preferred not to acknowledge them. Leprosy, after all, was tolerated only so long as it remained invisible, confined, and orderly. The layout of such institutions was deliberate. Wards were set at the periphery of complexes, rooms facing internal courtyards rather than streets. Patients could move about, exercise, or breathe in sunlight, yet remain hidden from casual observation. High walls and hedges ensured that the world outside remained unaware of who resided within and what condition afflicted them. In a city proud of its progress, architecture served as a buffer between reality and appearance. The disease could exist, but it need not be seen. Rooms themselves reflected both efficiency and invisibility. Each bed was spaced with precision, allowing staff to circulate freely while minimizing the chance of unmonitored interaction. Doors were positioned to separate patients from visitors, corridors designed to funnel movement without exposure. Windows were double-paned and often screened. Light entered, but the gaze of outsiders was denied. Even furniture was standardized, favoring practicality over comfort, designed to facilitate observation rather than intimacy. The environment was clinical, protective, and profoundly isolating. This careful design extended to circulation within the hospital. Patients moved along prescribed routes, exercises conducted on predetermined paths. Meals were delivered at exact times, often staggered to prevent congregation. Treatments were administered in specific rooms, with observation areas that allowed staff to monitor compliance without prolonged contact. Every aspect of movement was guided, controlled, and minimized where possible. It was not merely a hospital. It was a mechanism for containment, a spatial manifestation of society's desire to manage a disease that had been declared socially inconvenient. Isolation was both structural and symbolic. The further one was removed from central spaces, administrative offices, staff quarters, visitor areas, the more pronounced the separation. Patients on upper floors or peripheral wings experience the disease almost entirely within the architecture itself. Walls, corridors, and closed doors became both literal and metaphorical barriers. Visitors were discouraged, interactions were controlled. The very act of existing became choreographed to avoid acknowledgement. In this, the architecture mirrored the culture's silence. Leprosy was present, yet it was to be kept at a safe distance from the world that wished to forget it. Even communal spaces reinforced containment. Courtyards were divided with low walls or hedges. Gardens were sectioned. Exercise areas were limited and structured. Patients might walk or sit together, but always under supervision and within boundaries that prevented observation from outsiders. The disease could persist and spread among the confined population, yet remain invisible to the city beyond. Architecture became a vessel for social denial. And so, the hospital's physical form told a story. It declared control where control was partial. It promised care where care was constrained. It offered visibility to administrators while maintaining invisibility for patients. In every beam, corridor, and pane of glass, the building reinforced a fundamental truth of the Belle Époque. Leprosy could endure, but it must do so quietly, shielded by walls that spoke as loudly as any bell once had. Within this calculated isolation, the disease continued its slow, unrelenting work, its victims observed, managed, and contained, while society reassured itself that it had mastered what it refused to name. Routine in the hospitals of Belle Époque France was the closest thing to certainty. Every day unfolded according to schedules measured in hours and minutes. Meals arrived precisely at the same time. Nurses conducted rounds along predetermined paths, observing, recording, and attending to symptoms with brisk efficiency. Treatments, ointments, compresses, baths were applied according to established procedures, each step documented in careful handwriting. In this repetition, patients found structure, and in structure, society found reassurance. The disease could be managed, even if it could not be cured. Yet routine carried another purpose beyond efficiency. It established distance. Where once leprosy had announced itself through ritual, bell, and public vigilance, the Belle Époque had decided that disease could be contained quietly. Daily schedules ensured that interactions between patients and staff remained controlled, predictable, and minimal. Each procedure was an act of management rather than care. A bath, a dressing change, a measurement of temperature. These gestures were important, but their repetition emphasized control over intimacy. Patients were watched, treated, and recorded, but not truly engaged. Distance was reinforced through observation rather than conversation. Nurses and physicians moved swiftly through corridors, stopping briefly at each bedside, inspecting lesions, testing sensation, noting stiffness, measuring weight. Words were sparing, questions were functional. Empathy, when it occurred, was discreet, reserved for moments when reassurance was essential to maintain compliance rather than to comfort the patient fully. The body became the focus, the person a shadow accompanying it. Routine, in this sense, was a mechanism to reduce human entanglement while maintaining control over the illness. Patients learned to live within this choreography. They adjusted to the rhythms of the institution, predicting when physicians would arrive, when meals would be delivered, when rounds would pass by. Physical movement was guided by habit and expectation. Speech was measured, gestures minimized. Their presence was tolerated as long as it adhered to routine. Deviation, lateness, hesitation, display of pain or distress disrupted the carefully calibrated distance and was quietly corrected. Routine also concealed the disease from the world beyond. By ensuring that each day proceeded predictably, the hospital created an illusion of containment. Visitors and inspectors saw order and cleanliness, not slow deterioration. Staff documented compliance, not suffering. The system preserved the appearance that the disease existed only within its controlled confines, invisible to the broader society, that preferred to believe it had been eradicated. Over time, this daily repetition had psychological effects as profound as its administrative purpose. Patients became acutely aware of the limits imposed upon them. The rhythm of observation replaced engagement. Waiting for rounds, baths, and meals occupied consciousness more than conversation or connection. Isolation was normalized. The body's slow changes were noted clinically, but their meaning to the self and the family was often unspoken. Routine became a buffer between the individual and the world, between patient and caregiver, between disease and society. And so, the very order designed to protect became a tool of subtle confinement. In the hospitals at the edge of the map, leprosy endured not through overt neglect, but through the quiet efficiency of routine. Every meal, every bath, every recorded observation maintained a controlled distance, preserving social illusions while the disease continued its slow, relentless work. Here, in repetition and measured steps, the invisible became tolerable, and the persistent was rendered silent. The ledger in Belle Époque hospitals was a place of both knowledge and concealment. Medical records, those pages intended to preserve observation and detail, were crafted as much to manage perception as to document reality. Each entry carefully worded, each observation qualified, each diagnosis softened. Leprosy, officially forgotten, survived in these margins, not named boldly, but whispered in clinical phrasing, reduced to ambiguity to satisfy the sensibilities of administrators and society alike. The patient was rarely the focus. Charts recorded measurements, temperature, weight, lesion size, but rarely reflected the lived experience of the body within. Symptoms were catalogued in neutral language: skin irregularities, nerve involvement, chronic dermatological manifestations. Each term avoided the word leprosy, its presence implied, but never asserted. In doing so, the record protected the institution, minimizing responsibility while allowing care to continue at the most basic level. This minimization shaped the perception of the disease. Within hospital walls, leprosy existed, slowly altering bodies and lives. Yet, in reports sent to city health boards or published in medical bulletins, it became peripheral. Cases were described as isolated, exceptional, or even foreign. Statistics emphasized efficiency, recovery, and cleanliness, glossing over the slow accrual of disability and the invisible suffering of patients. To read the official documents was to encounter a world where leprosy barely persisted, its persistence softened by careful phrasing. The act of recording became a ritual of denial. Physicians learned to navigate the tension between observation and acknowledgement. Notes were written with caution, avoiding language that might suggest negligence or systemic failure. Each measurement, each description was hedged, precise enough to satisfy scientific curiosity, vague enough to maintain the illusion of control. By reducing the disease to numerical or textual abstraction, hospitals shielded themselves from scrutiny and society from discomfort. Families were aware, yet powerless. When records minimized reality, relatives relied on what was said, or more accurately, on what was omitted. Letters from doctors were formal, sparse, and euphemistic. Parents, siblings, and children pieced together knowledge from indirect observation. A nurse's glance, a corridor whispered conversation, the subtle progression of a lesion. Documentation provided guidance only in the narrowest sense. Emotional and practical support had to be improvised, often with insufficient understanding. Minimization also shaped patient experience. Those who read their own charts, or were told their diagnoses in cautious, indirect terms, encountered ambiguity. The disease existed, yet it was impossible to articulate fully. Patients navigated the hospital and their own bodies within the confines of official understatement. They endured silently in a space structured to observe without alarming, to manage without engaging. The consequences extended beyond the walls. By reducing leprosy in writing, the state and medical institutions reinforced its erasure in public consciousness. Society could imagine itself safe, modern, and purified, even while patients continued to deteriorate behind walls. The ledger became a barrier between perception and reality, between societal pride and human suffering. In these records, leprosy achieved a strange immortality. It persisted, acknowledged only through cautious phrasing and quiet implication. Every note that minimized the disease extended the life of the illusion, allowing the world outside the hospital to believe it had disappeared. And in that careful understatement, lives were regulated, suffering endured, and history itself was rewritten to suit the comfort of those who would not look too closely. Death, when it arrived in the hospitals of Belle Époque France, was measured and meticulous, but always distanced. Leprosy, in its slow persistence, often outlasted expectation. Patients lingered for years, sometimes decades. Their bodies gradually altered, while the world beyond the hospital walls maintained the comforting illusion of eradication. When decline became inevitable, society had arranged it so that the act of dying would be almost invisible, a private event performed quietly at the edge of perception, rather than witnessed, mourned, or commemorated publicly. In these hospitals at the periphery, the architecture itself facilitated invisibility. Wards were segregated, rooms isolated. Windows faced courtyards rather than streets. Corridors were long and echoing, ensuring that movement could be observed by staff, but not by casual visitors. The dying remained under supervision, attended in measured rotations, their passing noted in registers, rather than acknowledged in communal rituals. Death occurred under the gaze of the institution, not the society it served. Nurses performed the final rites with efficiency. Bedding was changed, tissues cleaned, temperatures taken until the last breath. Pain was managed sparingly, for both comfort and order, but human presence was calculated. Staff rarely lingered, and visitors were discouraged or carefully monitored. The patient's final moments were contained, regulated, sanitized, transformed into a medical observation rather than a human event. Families, when permitted, were present in limited numbers. They were instructed on hygiene, on procedural conduct, on how to act appropriately without disturbing the institutional rhythm. Their grief was muted, formalized, almost ceremonial in its constraint. A hand might be held briefly, a whispered word offered, but expressions of anguish were restrained. The hospital preserved the separation between life and the social spectacle of death. Outside these walls, society remained unaware. Leprosy, officially forgotten, left no trace in newspapers or journals. No public mourning, no communal memory. Obituaries were rare, if written at all. In the city, life continued in confidence, its streets sparkling, its cafes lively, its optimism intact. The slow decline of a patient, the final breaths taken at the edge of town, were invisible to the very society that had declared the disease extinct. This invisibility had consequences that extended far beyond the moment of death. Bodies were often interred quietly, sometimes in hospital grounds, sometimes in distant cemeteries, where proximity to the healthy population was minimized. Records listed names, dates, and minimal details, preserving order while concealing humanity. There was no public acknowledgement of suffering endured, no recognition of the resilience demanded by years of slow decline. Death was managed, controlled, and rendered socially neutral. The psychological impact on patients was profound. To live while unacknowledged, and then to die with such discretion, reinforced the isolation that had marked their lives. Every day of decline, every year of quiet endurance, culminated in a passing that mirrored the treatment they had received throughout, measured, observed, yet largely invisible. The disease persisted fully until its final act, but society witnessed nothing. Even physicians, trained to catalogue and monitor, felt the tension between duty and discretion. To record death was required. To acknowledge its emotional weight was optional. Staff maintained composure, chronicled decline, and ensured that the act of dying adhered to institutional expectation. In this way, leprosy patients were both observed and erased in the same moment, their final moments subordinated to the illusion of control. And so, in the peripheral wards of Belle Époque France, lives concluded quietly. Suffering, endurance, and death were all regulated, measured, and contained. Society, confident in its progress and cleanliness, remained oblivious. Leprosy ended its slow work out of sight, leaving no public record of its persistence. Only the faint traces in registers, whispers among staff, and the empty corridors that would soon welcome another patient into the same cycle of invisibility. Leprosy carried no trumpet. By the Belle Époque, it had lost the bells and proclamations that once marked its presence in towns and villages. There were no priests to ring warning, no crowds to recoil, no public decrees to isolate the afflicted. It had become, in society's eyes, an inconvenience to ignore rather than a catastrophe to confront. And yet, the absence of spectacle did not erase its power. Instead, it transformed fear into subtlety, cruelty into social choreography, and stigma into a quiet, pervasive presence. The stigma was woven into daily life, soft yet relentless. Friends and neighbours noticed changes that could not be concealed: an awkward hand, a slight limp, the stiffness of a smile. Yet nothing was ever named aloud. Conversation shifted around the patient. Invitations were offered sparingly, often delayed or modified in form. Attention was measured, affection moderated. The individual remained included in appearance, but always at a cautious distance. Politeness and propriety masked what was, in essence, avoidance. Families internalized the stigma, even without public enforcement. Children observed whispered exchanges, gestures of hesitation, the subtle distancing of relatives. Adults learned to manage the household around the afflicted, reducing shared contact, rearranging daily routines, and quietly reframing interactions. Care was given, yet constrained. Presence was maintained, yet carefully bounded. The lessons of observation became instinct. Avoidance was protection, discretion was virtue, and acknowledgement of disease was impropriety. Medical professionals perpetuated stigma by omission. Doctors recorded symptoms meticulously, but avoided direct naming. Patients were diagnosed with vague descriptors: chronic dermatological condition, nerve disorder, or minor neuropathy, allowing care to proceed without drawing societal attention. Labels were minimized to protect the institution's reputation and the city's confidence in progress. The patient's illness existed only within controlled environments and coded language, reinforcing a sense of secrecy and shame. The absence of spectacle made the social consequences more insidious. Leprosy's effects were no longer mediated by dramatic interventions, such as enforced quarantine or public exclusion. Instead, it acted invisibly, shaping relationships and perceptions without overt confrontation. The patient was not shunned openly, but subtly, through hesitation, avoidance, and muted conversation. Social death often preceded physical decline, as networks of trust and intimacy withdrew without explanation. The afflicted learned to censor themselves, modifying behavior, speech, and expression to minimize discomfort in others. Employers, too, participated in this quiet enforcement. Workers with early symptoms were tolerated only while performance appeared unaffected. Limitations were explained away, questions avoided, and eventually, disengagement or reassignment occurred subtly. The disease did not need proclamation to impose consequences. Its effects on visibility and productivity sufficed. Presence itself became a careful negotiation. Religious institutions offered moral frameworks without direct intervention. Clergy provided spiritual guidance, emphasizing patience, faith, and humility. Charity was administered, but at a distance. Pilgrimages, sacraments, and blessings occurred without drawing attention to the underlying disease. Moral sanction replaced physical isolation, reinforcing internalized shame and societal discretion. And so, leprosy persisted, not in noise or spectacle, but in the quiet regulation of attention. It shaped interactions, dictated space, and instructed behavior without ever being formally acknowledged. Stigma without spectacle proved more durable than the public panic of earlier centuries. It became invisible, internalized, and continuous. Patients learned to navigate a society that recognized them only in cautious glances, whispered assumptions, and the deliberate maintenance of polite distance. In this delicate balance, leprosy remained present, yet officially absent. It haunted the edges of society, shaping lives and relationships without ever drawing the eye of public alarm, teaching the enduring lesson that fear, when quiet, can be infinitely more pervasive than fear that shouts. Politeness had become the instrument of exclusion. By the Belle Époque, leprosy no longer announced itself with bells, proclamations, or spectacle. It had been declared obsolete, removed from public consciousness, and relegated to peripheral hospitals and discreet wards. Yet its presence persisted, and society, unwilling to confront it directly, perfected a subtler method: polite avoidance. It was a social choreography, learned over generations, executed with precision, and maintained by propriety rather than law. Avoidance began in small gestures. A handshake might be delayed, a touch lightly brushed aside. Conversation skirted sensitive topics. Visits were shortened or postponed. The patient remained present, yet subtly distanced. In cafes, theatres, and salons, eyes diverted. Words became neutral, carefully measured. Society had replaced the drama of public alarm with the quiet discipline of observation, where every interaction carried unspoken rules. Families, too, internalized these behaviors. Parents guided children with careful instruction. Do not linger, do not question, do not comment. Siblings learned to measure their attention, to soften gestures, to moderate speech. Meals were divided by habit rather than cruelty, with subtle shifts in seating and service. Children observed adults' hesitations and mirrored them naturally. Polite avoidance became instinct, a learned response that reinforced isolation without confrontation. Employment and public life were governed similarly. Workers with visible symptoms were tolerated only while they maintained appearances of normalcy. Supervisors adjusted duties quietly, reassigned tasks, or minimized interaction without explanation. Colleagues spoke around the affected individual, masking discomfort with cordiality. The disease itself rarely needed mention. Its social effects sufficed. The patient became a shadow within daily life, present enough to function, yet carefully excluded from intimacy or scrutiny. Medical practice mirrored these social codes. Doctors documented symptoms and monitored progression, yet reports and consultations were designed to avoid alarm. Euphemisms replaced explicit diagnoses. Chronic dermatological condition, nerve impairment, or persistent skin lesion appeared in notes rather than the word leprosy. Patients received care without the acknowledgement that might provoke scrutiny, while staff maintained distance under the guise of professionalism. Politeness dictated the boundaries of attention as much as clinical necessity. Polite avoidance created an invisible barrier. It was neither official isolation nor overt rejection. Instead, it operated through careful omission, measured behavior, and the shared understanding that the disease existed but should remain unspoken. Social networks adapted subtly. Invitations were rarely extended. Conversations were moderated. Physical proximity limited. The patient learned to anticipate discomfort, adjusting behavior to preserve civility. In this system, survival required compliance, not only with medical routine, but with the unspoken norms of discretion. Even within the hospital, avoidance prevailed. Nurses and physicians executed their duties efficiently, minimizing prolonged contact. Attention was functional, precise, and deliberate. Empathy was constrained to ensure compliance rather than comfort. Interaction was guided by protocol, not intimacy. The patient became an object of management, measured against expectations of order and efficiency. Politeness framed care itself, rendering human connection subordinate to the maintenance of social calm. In this manner, leprosy survived quietly. Polite avoidance ensured that the disease persisted without provoking disruption. Patients were neither publicly shunned nor openly supported. They existed in a liminal space, acknowledged only through the careful regulation of attention. Society, confident in its progress and hygiene, could maintain the illusion of eradication, even as the disease endured, shaping lives and relationships through the quiet power of restraint. In the dance of polite avoidance, leprosy exercised control indirectly. It dictated behavior, enforced separation, and rendered its victims invisible without a single bell, decree, or proclamation. In the Belle Époque, morality often outweighed medicine. France, proud of its progress, framed health not merely as a matter of physiology, but as an index of character. Clean streets, disciplined routines, and orderly conduct were read as evidence of virtue. Disease, conversely, was interpreted as a failure, an aberration, not just of the body, but of propriety. In this culture, leprosy, slow and invisible, became less a medical concern than a moral one, tolerated quietly, only so long as it did not disturb the social balance. Health was measured in appearance. Patients who maintained composure, dressed according to expectation, and adhered to institutional routines were judged acceptable despite illness. Their illness was permissible so long as it did not betray them publicly. Conversely, visible signs of progression, discoloration, lesions, muscular distortion, threatened social order and invited subtle censure. The body itself became a moral instrument, its obedience reflecting discipline, its deterioration hinting at failure. This framework influenced how care was administered. Treatment focused on maintaining visible cleanliness rather than on alleviating suffering. Wounds were washed and dressed, lesions kept sterile, hair and skin groomed, clothing arranged neatly. The hospital's priority was not the reversal of the disease, which was understood to be slow and unyielding, but the management of appearance. The patient's presentation mattered more than the illness itself. In maintaining external order, the institution preserved both its reputation and the illusion of societal progress. Families internalized these judgments. Children learned that illness required discretion. Spouses and parents adapted routines to prevent shame from entering the public sphere. Food, clothing, and space were adjusted to conceal deterioration. Affection was moderated. Care became a quiet exercise in propriety. The sick person was protected physically, yet constrained socially, enveloped in a moral architecture that prioritized perception over well-being. Physicians, too, navigated these moral imperatives. Even when clinical knowledge of leprosy increased, the practice of medicine remained, shaped by societal expectation. Documentation emphasized cleanliness, order, and compliance. Euphemisms replaced direct naming, softening the perception of chronic illness. Treatments were recorded meticulously, yet the patient's suffering remained secondary to the maintenance of the hospitals and the nation's moral image. Progress was judged in neat charts, not in the slow suffering of the body. This moral lens dictated social interaction as much as medical procedure. Visitors were admitted under conditions of strict propriety. Physical contact was limited. Conversation avoided topics that might reveal vulnerability. Patients learned to moderate gestures, speech, and expression to satisfy an unspoken moral code. In this climate, even minor lapses, tremors, delayed responses, changes in facial expression, invited judgment or subtle distancing. The disease itself was less feared than the disruption it implied to societal ideals of control and virtue. Over time, the prioritization of moral cleanliness over health shaped the very experience of illness. Patients became disciplined observers of their own bodies, modifying habits to preserve appearances. Decline was endured with discretion. Suffering was regulated not for comfort, but for propriety. And in the process, the disease, unacknowledged officially, persisted quietly, its victims constrained by invisible rules that demanded civility above all. In the end, leprosy in Belle Époque France was measured less in lesions or neurological decay than in the patient's ability to maintain dignity under scrutiny. Health was subordinate to morality. Survival required compliance with expectation, and the slow, relentless work of disease continued unnoticed in the shadows of civility. In Belle Époque France, charity was a performance as much as a practice. Philanthropic societies flourished, funding hospitals, endowing wards, and sponsoring clinics for the sick. Their generosity was celebrated in newspapers, praised in salons, and commemorated in plaques. Yet leprosy, that persistent and quiet disease, rarely benefited from such attention. It existed in spaces deliberately hidden, in bodies that had been carefully removed from the view of society. The help that arrived was measured, distant, and procedural. an abstraction of compassion, rather than an engagement with suffering. Donations were allocated according to visibility. Diseases that could be dramatized, outbreaks that demanded spectacle, crises that captured the public imagination, all received funding and attention. Leprosy, slow and imperceptible, could not be made urgent. Its victims lingered in marginal wards, beyond the eye of the city, and beyond the concern of donors. Hospitals treating leprosy were financed to maintain hygiene and safety, not to innovate cures or restore function. Charity ensured the disease was managed, not eradicated. The forms of aid reflected this distance. Patients received clothing, bedding, and basic sustenance. Physicians provided dressings, antiseptics, and baths. Meals arrived on time. Floors were kept clean. Ventilation was ensured. These interventions addressed the surface, hygiene, appearance, and routine, while leaving the deeper experience of the disease untouched. Relief was procedural rather than personal. It smoothed the experience of living with illness without confronting its consequences. Family involvement was similarly constrained. A patient's relatives might donate funds or items to the hospital, or arrange for supplemental care, but contact was limited. Physical and emotional presence was minimized to preserve the pretense of propriety and to avoid the stigma associated with leprosy. Affection was replaced by observation, concern by caution. The disease shaped domestic life as subtly as institutional protocol. Even religious charity followed this pattern. Clergy visited patients, offering prayers, sacraments, and spiritual guidance. Their presence was comforting in tone, but indirect in effect. Rituals substituted for intervention. Blessings replaced advocacy. Moral support was carefully structured, reinforcing the notion that suffering could be contained within the bounds of propriety. The spiritual benefit was evident. The medical impact remained marginal. This arrangement preserved the illusion of generosity. Donors could claim involvement without exposure to the harsh realities of chronic illness. Administrators could demonstrate social conscience while avoiding the messy work of direct engagement. Patients, meanwhile, continued to live under surveillance, their suffering managed at a distance, their needs partially met, their humanity only lightly acknowledged. Charity, in this sense, became a tool of social order. It reinforced boundaries, dictated proximity, and confirmed the social hierarchy of attention. Aid was granted, but only in ways that maintained discretion. Suffering could exist, but only within parameters carefully controlled by those with power, visibility, and social capital. In the wards where leprosy persisted, this form of charity defined daily experience. Patients endured provisioned lives, shielded from extreme neglect, yet denied genuine restoration. They learned the rhythms of aid without intimacy, comfort without touch. Their survival depended as much on adherence to institutional routines as on the interventions meant to help. And so, in Belle Époque France, generosity existed without engagement, care without connection, and charity became a mirror of society's distance, an expression of benevolence that polished appearances while leaving the disease and its victims quietly to endure. Religion in Belle Époque France had become a measured solace. The clergy, aware of the human fragility surrounding leprosy, offered ritual, prayer, and moral guidance, but always at a distance that preserved social propriety. Compassion was framed by doctrine, administered within the bounds of ritual and etiquette, and carefully separated from physical intervention. The sick were instructed to attend Mass, recite prayers, and reflect upon virtue, yet the disease itself was rarely confronted directly through medical advocacy or social integration. Spiritual care was deemed sufficient to temper suffering, even as the body decayed quietly within peripheral wards. Priests and nuns approached patients with discipline, not intimacy. Visits were scheduled and brief, the focus on liturgy rather than conversation. Communion, blessings, and confession became instruments of moral reassurance rather than therapeutic engagement. Patients were expected to participate obediently, recite prayers diligently, and internalize guidance quietly. Emotional distress was acknowledged only insofar as it could be framed in religious terms: patience, humility, and piety, never as a direct response to the disease's relentless progression. The rituals themselves reinforced isolation. Mass was attended in designated hospital chapels, small rooms that prevented public observation, yet emphasized segregation. Communal prayer offered a semblance of connection, yet proximity was limited. Speech was formal, and touch restricted. The religious experience became symbolic, a demonstration of faith that simultaneously acknowledged and obscured the illness. Patients were spiritually present, but socially peripheral, their suffering managed through propriety rather than direct engagement. Religious charity followed the same patterns of discretion. Donations from parishioners supported basic needs, bread, linens, and minimal comforts, but rarely targeted medical innovation or interventions that might alter the course of disease. Clergy were careful to avoid situations that might draw attention to the disfigurement or suffering of leprosy patients. Visits were ceremonial rather than personal, comforting in tone, but not transformative. This reinforced the moral separation of the afflicted from society while preserving the illusion of benevolence. Families were instructed to frame care in moral terms. Children and spouses were taught to consider patience and obedience virtues. Touch was moderated to maintain propriety. Affection was expressed indirectly through attention to routines, ritual participation, and silent observation. Moral instruction replaced explanation. Guidance substituted for intervention. Compassion existed, but only within the carefully prescribed limits of social expectation. Even physicians, when integrating spiritual support, were influenced by this framework. Medical notes occasionally referenced participation in religious practices, recording compliance rather than comfort. Clerical visits were logged alongside dressings and temperature checks, suggesting equivalence between ritual and treatment. In this way, religion became part of the institutional strategy to manage disease, reinforcing both control and distance, while providing patients a framework through which to endure slow decline. The psychological weight of this structure was profound. Patients learned to reconcile the slow devastation of their bodies with assurances of spiritual grace. Faith provided structure, meaning, and ritual, yet it could not halt physical deterioration. The mind and soul were nurtured at a distance, while the body continued its unrelenting work. Endurance became both moral and medical, an expectation to bear suffering with patience, internalizing isolation as a virtue. In Belle Époque France, then, religion became a buffer. It offered acknowledgement without disruption, consolation without proximity, and moral guidance in lieu of intervention. The sick were comforted, but not restored, recognized, but not fully seen. Compassion existed in measured forms, reflecting the broader societal desire to maintain order, propriety, and the illusion of mastery over the disease that continued quietly at the edges of awareness. In Belle Époque France, containment was as much an idea as a practice. Hospitals, sanatoria, and peripheral wards were meticulously designed to control the visible aspects of leprosy. Beds arranged with precision, corridors structured for observation, gardens and courtyards that permitted exercise while minimizing exposure. Visitors were restricted, schedules were regulated, and staff movements were calculated. On paper, these measures suggested mastery. The disease had a place, carefully circumscribed, contained both spatially and socially. Society believed it was in control. Yet the myth of containment was just that, a myth. Leprosy, slow and insidious, did not respect boundaries. It advanced within bodies, regardless of the surrounding order. Its progression was invisible, measured not in dramatic outbreaks, but in subtle loss of sensation, the gradual stiffening of muscles, the silent disfigurement of features. Patients were monitored, yes, yet the monitoring often served appearances rather than intervention. Observation replaced treatment. Discipline substituted for cure. The disease continued, unrelenting, beneath walls that promised control. Staff participated in the illusion knowingly. Nurses and physicians recorded symptoms meticulously. Yet, the emphasis was on documentation rather than solution. Registers noted temperature, lesion dimensions, and mobility. Recovery rates were calculated in sanitized statistics that ignored the slow accrual of disability. Observations were logged carefully, yet rarely did they prompt decisive action. Routine became a substitute for cure. Repetition a bulwark against uncertainty. Containment existed in the architecture, the schedules, the charts, and the social rituals surrounding the patient, but not in the body itself. Patients were caught within this paradox. They were confined, observed, and disciplined, yet never fully treated. Daily life was governed by institutional order, and each day of compliance reinforced the sense that the disease was under control. And because the world outside the hospital walls was led to believe the disease had been eradicated, patients found themselves both enclosed and invisible. Isolation was framed as safety, compliance as normalcy, and endurance as virtue. The myth of containment was lived as reality, even by those it failed most. Families, too, were implicated. They were instructed to respect boundaries, maintain distance, and modulate affection. Touch was limited. Conversation was measured. Homes were adapted to minimize exposure. The illusion of control extended beyond the walls of the institution, shaping domestic life. Relatives were told the disease could be managed discreetly. They learned to treat it as a matter of propriety rather than medical urgency. Their fear, internalized and coded as discretion, reinforced the containment myth. Even public health authorities relied upon it. Reports emphasized order, cleanliness, and structural efficiency. They highlighted the absence of dramatic outbreaks and the perceived success of institutions. Leprosy became a problem that had been relegated to the edges of society, managed quietly, and removed from statistical scrutiny. The disease existed, but only as a controlled anomaly, a hidden reminder that reality had limits, even in an age of apparent mastery. And so, containment became a narrative. The disease persisted, yet the story told to the public was of mastery, of progress, of hygiene and regulation. Patients remained within walls, enduring slow decline. Staff continued their routines, reinforcing the illusion. Families complied with social expectations. Society, reassured by appearances, believed the disease had been captured, subdued, and neutralized. But the walls could not stop it, the schedules could not halt it, and the myth could not erase it. Leprosy endured quietly. Beyond the reach of both belief and bureaucracy, a silent testament to the limits of control in a world convinced it had mastered the unseen. When France spoke of disease, it often spoke of it as distant. Leprosy, inconvenient and unyielding, was gradually cast beyond the borders of the metropolitan landscape. In the colonies, Algiers, Indochina, the islands of the Pacific, the disease could persist without disrupting the polished streets of Paris or the gleaming boulevards of Marseille. It was a form of geographical exile. Patients relocated, treated, and observed far enough from the city to preserve the illusion of modernity, yet close enough for oversight and documentation. The peripheries became laboratories of distance, where illness could exist quietly, controlled at a remove. Colonial institutions were structured with purpose. Hospitals and sanatoria mirrored those at the edges of French cities. Wards isolated, corridors regulated, courtyards enclosed. Patients were observed meticulously, recorded systematically, and treated within routines that emphasized hygiene, containment, and propriety. Unlike metropolitan hospitals, however, these spaces were doubly removed from the public scrutiny. They existed in lands already framed as other, a context where suffering could be contained not only physically, but conceptually. Distance became a tool of control. The further from home, the more manageable the disease appeared. Patients were aware of their exile. They understood that their relocation was both care and separation. Transported across oceans or to remote settlements, they entered institutions that offered shelter and supervision, yet reinforced isolation. The disease no longer intruded upon familiar streets or social networks, but neither did relief arrive in the form of acknowledgement or true engagement. They existed in the margins of empire, observed by doctors, monitored by administrators, yet largely absent from the consciousness of the society that had sent them away. Colonial authorities framed this displacement as benevolent. Relocation was justified as treatment, protection, and moral obligation. Maps recorded hospitals, registers logged arrivals and departures, and reports emphasized cleanliness, routine, and the absence of public outbreaks. The narrative suggested mastery and care. In truth, the move also served convenience. Leprosy could be managed far from those who might feel shame, fear, or discomfort, preserving both the city's image and the illusion of control. Local populations often absorbed these institutions as peripheral realities. The afflicted were integrated into colonial wards, their presence acknowledged in terms of duty rather than human experience. Staff applied treatments, maintained hygiene, and monitored compliance, but emotional and social engagement remained minimal. The disease persisted, yet its victims were disciplined, contained, and rendered socially invisible. Geography itself became a mechanism of denial. Families of patients faced compounded absence. For those who remained in France, distance magnified separation. Letters, occasional visits, and reports replaced proximity. Emotional support was fragmented. Physical care impossible. Patients were alive, yet removed from the relational world that once sustained them. Exile became a persistent condition, shaping both bodies and psyches over time. Even medicine benefited from the distance. By observing patients in colonial settings, physicians could study leprosy as if it were exotic, abstract, and safely contained. Reports emphasized structure, hygiene, and slow progression, reinforcing professional expertise while downplaying urgency. The disease became both observable and untouchable, present enough for science to note, but distant enough to avoid confrontation. In these remote institutions, leprosy survived quietly. Exiled beyond Parisian pride, beyond Marseille's order, beyond the gaze of a society eager to celebrate progress, the disease continued its slow, unrelenting work. Bodies deteriorated under observation, patients endured in isolation, and the illusion of mastery remained intact. Geography, more than medicine, became the tool of containment, preserving the comfort of civilization while the disease endured, distant but persistent. In the Belle Époque, disease was never neutral. Leprosy, slow and unassuming in its progression, became entangled not only with medicine, but with the prevailing notions of race, empire, and social hierarchy. Its presence in metropolitan France was considered inconvenient, yet manageable. In the colonies, it was framed differently. Here, diagnosis was filtered through a lens of racialized assumption, where the disease was more readily attributed to those deemed foreign, exotic, or other. The patient's skin color, origin, and perceived ancestry shaped both the speed of recognition and the degree of intervention, creating a hierarchy of attention that mirrored societal prejudice. Physicians trained in Paris often carried assumptions abroad. Colonial hospitals, staffed with doctors and nurses educated in metropolitan ideals, categorized leprosy as a disease of distant lands first and of distant peoples second. European patients were noted, treated, and quietly accommodated, their affliction framed as unfortunate but manageable. Non-European patients were observed differently. Signs of early lesions prompted classification, segregation, and at times, exaggerated concern. The body's decline was interpreted through racialized expectation, rather than solely through medical observation. Diagnosis became a measure of social distance. A native laborer in Indochina or Madagascar could be diagnosed quickly, documented systematically, and isolated without question. The same symptoms in a French settler might be noted and monitored over months, if at all, as physicians hesitated to label a citizen with a disease officially considered obsolete. The disease itself did not discriminate. Doctors did. The perception of risk and the urgency of treatment were calibrated according to the patient's social and racial identity, leaving some to languish unnoticed, while others were treated meticulously, if distantly. Even metropolitan authorities reinforced these hierarchies. Reports emphasized the imported nature of cases, highlighting the colonial origin of patients, rather than acknowledging local persistence. Statistics catalogued disease geographically and racially, framing it as a problem external to the nation. The narrative was convenient. The metropole remained healthy, ordered, and modern, while the colonies absorbed the inconvenient and visible consequences of slow decline. Leprosy became both a medical and moral concern for the other, yet a silent, manageable nuisance for the French citizenry. Families felt the weight of this distinction. A European family might endure minimal intrusion, their relative monitored discreetly within urban hospitals. For colonized subjects, families were often excluded entirely. Decisions about isolation, treatment, and relocation were made by authorities without consultation. reinforcing dependence, marginality, and social erasure. Suffering was present, but agency was absent. Racialized diagnosis also influenced medical research. Physicians documented cases in ways that emphasized difference, often correlating symptoms, severity, and progression with perceived racial characteristics. The disease became a study of the exotic, a subject to examine in laboratories and hospital records far from the Parisian streets, where it had long been declared obsolete. Scientific interest masked moral neglect, and the slow persistence of the illness was reframed as a predictable outcome for the non-European patient. Through these practices, leprosy persisted in both body and social imagination. It continued its unhurried work in patients whose visibility was mediated by racialized assumptions. Diagnosis, care, and surveillance were determined as much by prejudice as by pathology. And while metropolitan France congratulated itself on progress, hygiene, and the eradication of old fears, the disease endured quietly, measured and managed in ways that reflected both empire and bias, and the human cost remained largely unseen. Geography in Belle Époque France became a mechanism of forgetting. Leprosy, slow and insidious, had been inconvenient enough in metropolitan hospitals. It became far easier to ignore when removed entirely from the familiar streets, squares, and avenues of Paris, Marseille, or Lyon. Distance, both literal and conceptual, transformed the disease into a peripheral problem, a matter to be observed in far-off institutions, documented in registers, and noted in clinical journals, but rarely acknowledged in the consciousness of the society that had long ago declared itself cured. The placement of hospitals and sanatoria at the geographical margins was deliberate. Wards were established in rural provinces, along riverbanks, away from city thoroughfares, or on colonial outposts across the empire. Patients were transported under supervision, their arrival and departure carefully managed to minimize exposure. In these remote locations, disease could progress at its slow pace, observed but contained, measured but hidden. The farther from the metropole, the more effective the illusion of eradication appeared. A case in a distant town or colony was an anomaly, a curiosity, not a threat. Distance shaped perception as much as treatment. Patients relocated to peripheral institutions often experienced life removed from social memory. Their families remained at a distance. Visits were sparse, and social networks thinned to near invisibility. Observers, administrators, doctors, and nurses regulated their exposure carefully, noting progression in clinical terms, but rarely considering the human cost beyond protocol. The disease was visible only to those whose professional duty demanded attention. To the public, it had ceased to exist. Geography became a shield, rendering suffering invisible, while reinforcing the nation's self-image of health and modernity. Colonial locations amplified this effect. Leprosy in Algeria, Indochina, or Madagascar was framed as an external problem, a disease of other lands and bodies. Reports emphasized climate, geography, and the exotic origin of patients, rather than continuity with domestic cases. European observers interpreted persistence as natural for distant lands, diverting attention from domestic neglect. Disease was not erased entirely, but its presence in distant regions reassured metropolitan authorities that it no longer threatened their streets, institutions, or social ideals. Even within metropolitan borders, distance was symbolic. Hospitals at the outskirts of cities, removed from the public eye, created the perception that disease was under control. Patients who had once been treated in urban centres were transferred to provincial wards, monitored systematically but unseen. Registers documented their existence, yet reports to the city emphasised containment and efficiency. The disease endured physically, yet socially it was absent. Geography allowed society to believe it was cured without confronting the ongoing reality. Distance shaped the psyche as well as the body. Patients internalized their marginality, adapting to lives structured around isolation and observation. Families learned to maintain caution. Interactions were mediated by proximity, and communities quietly avoided engagement. Even death occurred at a remove, documented in registers and burial logs, but largely invisible to those who might mourn publicly. Geography became not just a physical separation, but a conceptual one, enforcing both isolation and forgetting. In this way, leprosy persisted despite proclamations of progress. It endured in bodies, in institutions, in registers, and in the shadowed margins of maps. Geography, carefully manipulated, allowed society to forget its presence, while the disease itself continued its slow, unrelenting work. Distant, silent, and unavoidable, yet officially absent from the consciousness of the world that preferred not to see. Leprosy in Belle Époque France was a disease without closure. Its progress was measured not in crises, but in persistence. Whereas other maladies flared, receded, and resolved, leprosy endured in the quiet spaces where observation substituted for intervention. Patients carried it through years, decades even, their bodies slowly altered, while society reassured itself that the disease had been eradicated. These were cases that never ended, not because medicine failed entirely, but because the structures of acknowledgement, care, and social attention had been carefully minimized. Within hospitals, the disease was catalogued meticulously, yet incompletely. Registers noted skin changes, nerve deterioration, and the gradual loss of sensation. Physicians recorded temperature, weight, and response to topical treatments. Each measurement reinforced the semblance of care, yet it was care conducted within strict boundaries of observation, without sustained engagement, without acknowledgement of the human consequences. Improvement was expected in theory, but rarely achieved in practice. Patients were observed continuously, while progress remained elusive. Time itself became a mechanism of endurance. Weeks passed into months, months into years. Patients adapted to limitations, modifying movement, daily routines, and social interaction. They learned the rhythms of institutional life, anticipating visits, inspections, and treatments. Their bodies continued to decline slowly, each day adding imperceptible shifts that cumulatively transformed appearance, dexterity, and sensation. The illness did not hurry, yet it advanced relentlessly, indifferent to the schedules, expectations, or illusions of control imposed by the medical establishment. The institutions themselves reinforced the persistence of these cases. Sanatoria and wards were designed for long-term occupancy. Patients were provided with beds, routines, and supervision, but not with curative interventions that might have altered the natural course of the disease. Distance, both physical and social, was maintained to preserve propriety and avoid public discomfort. Each day of adherence became a measure of survival rather than recovery. Life continued within these walls, regulated and predictable, but never fully liberated from the grasp of the disease. Families of patients experienced a parallel endurance, separated by distance, stigma, or social expectation, Relatives were often excluded from meaningful participation in care. Communication was limited, visits infrequent. Support became ritualized, functional rather than intimate. The slow decline of the patient, observed quietly over years, reshaped family life, altering patterns of interaction, emotional labor, and memory. Relationships were maintained, but subtly modified to accommodate the enduring presence of illness. Even in death, cases never truly ended. Patients passed quietly in wards removed from the public observation. Registers recorded names and dates, sometimes noting cause of death. But the continuity of suffering was rarely acknowledged beyond these entries. Families might mourn privately, but society's memory remained selective, focused on hygiene, efficiency, and the myth of eradication. Each life, measured in years of quiet decline, left traces in documentation, but not in collective awareness. The unending nature of leprosy underscored a profound truth. It was not the dramatic outbreak that defined the disease, but its persistence. It endured in bodies, in registers, in institutions, and in the quiet memory of those who bore witness. Modernity could ignore, conceal, and relocate it, but the disease itself obeyed neither propriety nor policy. Each case that continued without resolution was a subtle reminder that society's triumph over illness was provisional, imperfect, and incomplete. In the wards of France, leprosy persisted, unhurried, unacknowledged, and unrelenting, a disease that never ended, even when it was declared long gone. Neglect, though seldom acknowledged, left its mark far beyond the hospital walls. In Belle Époque France, the absence of urgency in addressing leprosy created consequences both visible and insidious. Patients endured years of slow deterioration, observed but rarely intervened upon, while society congratulated itself on the triumph of modernity and hygiene. Each case left behind a legacy that was more than medical. It was social, psychological, and deeply human, a shadow that extended across families, institutions, and communities. Within the wards, the impact of neglect was immediate and cumulative. Patients were monitored meticulously, skin changes recorded, nerve function tested, temperature and mobility noted. Yet observation was substituted for engagement. Treatments were applied in routine, with no expectation of reversal. Pain was addressed only to the extent necessary to maintain compliance, and emotional distress was often overlooked entirely. The body was catalogued. The person within it was secondary. With every passing year, the slow accrual of disability became normalized, an expected outcome of both disease and systemic indifference. Outside the hospital, neglect manifested in invisibility. Families were instructed in restraint, visitors guided by discretion. Communities avoided engagement, subtly reinforcing isolation. The disease remained unacknowledged, not because it had disappeared, but because acknowledgement carried social cost. Polite avoidance and moralized cleanliness ensured that suffering remained peripheral, quietly tolerated, but never fully confronted. Patients endured a form of social erasure as profound as any physical affliction. Neglect also shaped the psyche of the afflicted. Living in constant observation, yet without advocacy, patients internalized the societal silence. They learned to manage symptoms discreetly, to modulate gestures, to control expression. Fear, anxiety, and shame became companions, quietly reinforced by the routines and boundaries of institutional care. Even as bodies deteriorated, minds were conditioned to conceal both need and distress, creating a psychological landscape shaped by absence as much as by disease. Institutions themselves bore the imprint of neglect. Registers and medical journals emphasized efficiency, cleanliness, and compliance, not progression or recovery. Cases were noted, categorized, and observed, but rarely revisited with innovation or individualized attention. Procedures reinforced stability and order rather than improvement. The hospital became a space where disease could exist indefinitely, observed yet unaltered. Its persistence interpreted as the natural course rather than the product of limited intervention. The long shadow extended to society's perception. By framing leprosy as rare, exotic, or relegated to distant colonies, France maintained the illusion of mastery. Public reports celebrated containment, hygiene, and progress, while the enduring presence of disease was minimized. Knowledge of the affliction remained compartmentalized. Administrators, physicians, and colonial officials understood its persistence, but broader society was reassured that modernity had prevailed. Ignorance was protected, and neglect institutionalized. Even in death, neglect left traces. Patients passed quietly in peripheral wards or distant colonies, often without ceremony or acknowledgement. Registers documented life's end, but public memory remained absent. Families mourned privately, rarely recognized publicly, while the disease itself faded from collective awareness. Its consequences recorded only in fragments, its persistence invisible to the very society that had chosen to ignore it. The long shadow of neglect was thus a paradox. It preserved social confidence while allowing suffering to continue. It maintained appearances while failing the living. And it ensured that leprosy, slow and unrelenting, endured quietly in bodies, in records, and in the memory of those who bore witness. Its presence a constant reminder of the limits of an era convinced of its own progress. Time, in Belle Époque France, was both ally and adversary. By the close of the 19th century, society had fashioned a narrative of progress, hygiene, and triumph over the maladies of the past. Leprosy was said to belong to the Middle Ages, a relic of a time when illness demanded spectacle, fear, and ritual. Streets gleamed under gaslight, boulevards were swept clean, and the press celebrated scientific advancement. Within this triumphant narrative, the disease had been erased, not cured, not conquered, but conveniently forgotten. Yet forgetting could not undo presence. Patients continued to endure the slow, unrelenting work of the disease. Their bodies bore witness to decline, their nerves betrayed sensation, and their faces carried the subtle signatures of time and affliction. Hospitals monitored them carefully, observing, recording, and managing, without addressing the deeper consequences. Sanatoria provided structure, colonial wards offered distance, but the illness persisted, unacknowledged in public discourse, silent in official registers, and largely invisible to the society that had declared itself immune. Families experienced the consequences of collective forgetting. Children grew up witnessing subtle alterations in posture, expression, and ability. Spouses adapted routines, moderated touch, and learned to speak around the illness. Generations internalized the unspoken rule. The disease was present, yet invisible, real, yet unspeakable. Domestic life was quietly reshaped by absence, hesitation, and measured care, producing both endurance and alienation. Love, attention, and grief were all filtered through social expectation, creating a human cost far beyond clinical observation. Even medicine had been complicit. Physicians, trained to value progress, efficiency, and visible outcomes, had prioritized diseases that demanded immediate intervention or offered measurable recovery. Leprosy, slow and resistant, fell into the shadows of professional attention. Registers minimized cases, euphemisms replaced explicit naming, and treatment focused on surface management rather than comprehensive care. Observation became a substitute for engagement, documentation a substitute for action. The body suffered in silence, while the ledger suggested control. Colonial displacement amplified the illusion. In distant hospitals and remote wards, patients lived under supervision, but beyond public notice. Their disease was catalogued, measured, and contained, yet society remained confident that the metropole was free from threat. The distance reassured those who claimed mastery over illness, even as the disease endured, shaping lives without acknowledgement, and leaving long shadows in human experience. By the time historians and public health authorities revisited these cases, it was often too late. Records existed, but they were fragmentary, scattered, and mediated by euphemism. The lived experience of patients, the endurance, the isolation, the slow disfigurement, the quiet suffering, was difficult to reconstruct. Society, having believed itself cured, had left behind a population marked by illness and invisibility, whose stories were preserved only in fragments, their human dignity acknowledged belatedly through hindsight rather than contemporaneous action. Leprosy's persistence revealed the limits of belief, policy, and control. It outlasted proclamations, defied bureaucratic convenience, and endured despite social and moral frameworks that attempted to suppress recognition. The disease was neither spectacular nor dramatic, yet its slow progress challenged assumptions, revealed prejudices, and exposed the human cost of neglect and denial. In the final reckoning, society remembered leprosy too late. Its victims had already endured the full weight of disease, isolation, and marginalization. The streets, once gleaming with confidence, could not reclaim the lives that had been quietly consumed. Institutions could document progress, but they could not reverse absence. And the disease, though unspoken for decades, remained a testament that forgetting, no matter how polite or deliberate, cannot erase suffering. Leprosy in Belle Époque France persisted not only in bodies, but in memory, revealing the tragic consequences of a society that chose appearance over acknowledgement, progress over care, and silence over truth.